Thank you for coming to talk about climate change and the impact on our children. My name is Matt Strehlow. I am an associate professor at Stanford University. I'm the director of Stanford Emergency Medicine International. And I'd like to introduce Dr. Kyle Martin. Everybody round of applause. What a timing. Go ahead. That's your coffee. That's your
you
bread.
got me a coffee?
That's your
why
table.
I was late.
No, I'm not stupid. If I invite you to be on a panel, I get you coffee and I get you bread. So there's no money, unfortunately. It's climate change. There's no money. So, all right. So now that Dr. Martin has made their grand entrance, we will introduce the rest of our panelists. So Dr. Hannah Lindstadt is an emergency physician in Sacramento, California. Dr. Lindstadt, raise your hands. Oh, after attending residency at Stanford, she completed the Climate and Health Science Policy Fellowship at the University of Colorado. Her past work includes a series of publications relating to various aspects of climate change and health, the development of a comprehensive climate and health medical school electives, and investigating methods to make emergency departments more climate smart by decreasing their carbon footprint and increasing their resiliency. She currently serves as SAEM's Climate Change and Health Interest Group Chairperson with the goal of increasing emergency physicians' awareness and interest in climate change and human health. Dr. Caitlin Rubley is an assistant professor in the Department of Emergency Medicine at the Medical College of Wisconsin and Institute for Health and Equity. She completed her medical school and public health training at the University of Wisconsin School of Medicine and Public Health and a residency at Ohio State. She then completed the Climate and Health Science Policy Fellowship at the University of Colorado in 2020 before returning to Wisconsin, where she's faculty and she teaches global environmental health and has worked to mitigate and adapt to the effects of climate change through policy on a local to global scale. She serves on the steering committee for the Medical Society Consortium on Climate and Health and board of directors for Wisconsin Health Professionals for Climate Action. Her focus is on climate-related disaster preparedness and for health systems. And our final panelist is Dr. Kyle Martin, who did his own introduction, but he is an assistant professor of emergency medicine and the associate director of the Global Emergency Medicine Fellowship at Brown University. He received his doctorate of osteopathy from Michigan State, and he received a Master's of Arts in Bioethics and a Master's of Public Health from Michigan State. Dr. Martin completed a specialty training in emergency medicine at Henry Ford in Detroit and got a diploma in tropical medicine and hygiene from the London School. Has a certificate as well in knowledge in clinical tropical medicine and traveler's health from the American Society of Tropical Medicine and Hygiene. Dr. Martin has taken the lead at integrating climate change and health into the medical school curriculum at Brown. His research focuses on the carbon footprint of emergency systems and humanitarian endeavors. So thank you, panelists, for coming. I really appreciate it. Okay, everyone? There we go. Really appreciate your time and expertise. I'll just start by saying that I have 3 children, and we spend, it's amazing to me how much my children know about climate change as compared to my colleagues, as a general rule. And one of the things that also amazes me about that is that we know that children have the least responsibility for where we're at with climate change and global warming, but they are the ones that are going to, by far, feel the effects. 90% of the effects of climate change are going to impact our children. And so, thinking about this from their perspective really inspires me to try to learn from experts like these that we have here today. So I have some questions that I've kind of designed to ask our panelists, but I really want this to be interactive if possible. We have a small group, and there's nothing like a discussion among a small group to kind of push that conversation forward. So if you want to raise your hand at any point, we can take questions. We don't have to wait till the end. And if you have something you want to add to a question that's been already asked or things like that, please feel free to go ahead and do so. So I want to get us started by asking Dr. Lindstadt a question. Where do we stand with our global efforts right now, just kind of generally, to reduce climate change?
Awesome.
It's on.
So great question. We stand, I think, at a really interesting time and a really critical time right now. So I'm not sure, how much everyone knows about what's going on in terms of climate change currently, but essentially the last 7 years have been the hottest on record. The last 2 years have been the highest billion-dollar disaster years in history for this country. We're already warmed to about 1.1 degrees Celsius over pre-industrial times, whereas we really, really want to keep that number down to 1.5 degrees Celsius, or below 1.5 degrees Celsius, in order to prevent some pretty catastrophic effects on human health in the future. We're expected to hit 1.5 by the end of this decade. It's already 2022. We are into this decade. So we really, really don't have a whole lot of time left to really get some work done. I think that the optimistic part is that we actually have solutions. We know what we can do, and we can implement things. So by moving towards renewable and clean energy, by moving towards electrification to apply or to use renewable energy, these are solutions. All we have to do is decrease our carbon dioxide emissions, which obviously is a very complex thing to do, but we know that that's what we need to do. So the fact that we have an answer is actually really, really reassuring. Also, there's something called the Paris Agreement that I'm not sure if anyone's familiar with, but essentially about 200 countries signed the Paris Agreement, and they are working, these 200 countries are working towards net zero carbon emissions by mid-century. I can't imagine anything else in the world that 200 countries agree upon and sign something. We are committed as a world to helping mitigate climate change. And, a handful of them are already at net zero. Many of them are trying to decrease emissions in half by about 2035 or so. And quite a few are really working hard towards being net zero carbon by 2050, which is what we need to do. So while right now, in 2022, seems very doom and gloom all the time, you open the newspaper, it seems very pessimistic. But I think the fact that we have global agreement that we need to do something, and we know what that something is, that's incredible. And we have a huge, huge opportunity to turn everything around.
Thank you. That's a positive approach, though, I think. So there is a chance that we will adhere to the Paris Agreement and see. Dr. Martin, how, as the Earth continues to warm, how do you think, what are some of the impacts that we're going to see from climate change? I think we're seeing some of them, but can you kind of summarize some of those, and what are the ones you're most concerned about and you think are going to be most impactful to human health?
Yeah, I think each of us in the places where we come from geographically can see the effects of climate change on our own personal lives. If you live in California, if you live in the Western United States, then you've undoubtedly had to deal with some effect of wildfires, whether it be the direct effect of wildfires on your community or smoke that's migrated from the wildfires to your state. And if you live where I live on the East Coast, I've been seeing hurricane-force winds more this year than I've seen any year that I've lived out there. And people are having to adjust their homes to reinforce them and protect them from these new changes that are taking place directly as a result of man-made climate change. You also see examples of flooding in places that you've never seen flooding before. And flooding can have short-term and long-term effects. The short-term effects are the obvious flooding, but the long-term effects are molds and the release of chemicals from construction materials that can leach into water supplies, local water supplies, and can be present there and have effects downstream, quite literal, pun intended. So there are a variety of different effects that you can see based on climate change, and some that we probably won't know for decades to come. For example, like what the effects on coral reef destruction are going to be on our marine life, and how that's going to downstream affect human beings and our food sources.
I have a question almost for the audience, maybe by show of hands as well, which is, we've seen a lot of extreme weather events and fires and things like that over the last few years. And Despite the science being very strong, that climate change is a human-initiated change to the environment, the general consensus wasn't as strong among the population. Do people feel like in the communities from which they come, I'm trying to think broadly about the communities in which they come, that those extreme weather events and all of this attention to these extreme weather events and fires and hurricanes and things has changed that narrative among the general population? Right? Is it like the scientific community has consensus, nearly 100% consensus, but it was more like a 60-40 among the general population or a 55-45? Do we feel like that's shifted over the last few years with all of these extreme weather events? Anyone from the audience?
I feel like it may be a little teeny bit. I mean, I watch the evening news, and nobody's saying, this is like the 12th day in the last 2 months that we've had over 60-mile-an-hour winds, and this is directly related to climate change. I don't know why you watch the same channel, but we're in the same area. So you're not watching news?
I think that in the community, many people, I guess it depends on where you are. But even where I am now in the Northeast, it's surprising to me the lack. I thought there would be more understanding than there is. But I think that the needle has shifted.
Okay.
Yeah.
And I would agree. I think it's when you think of your community, if you're within a community of people who are environmentally conscious, those people are more aware. They have more details, they have more knowledge. And at the same time, there is a group of people who still are not aware. And there is a group of people who say, these things always occurred before. They're just, in the news now. And that's why you're hearing them. So, unfortunately, we have a larger population.
Yeah, please. I was going to ask if there was any evidence on this question.
I think that to a certain degree our messaging is off. I think all three of us read this book by Catherine Hayhoe. I can't remember what it's called. Do you guys Saving Us? Like, this is an easy enough title to remember. But it's a great book. I would recommend it.
Can you say it again?
Saving Us by
Saving
Catherine Hayhoe. I did get royalties for saying that during this time.
Especially 4 times, yeah.
And I tricked Hannah into saying it too. But it's a great book, and what she talks about is like, how can you communicate with people who might disagree on the topic of climate change and convince them to adopt more climate-friendly policies. And I think, the argument that I use with a lot of people is, don't you want, like, I said this during my presentation the other day, nobody likes their electric company. Is there anyone out there who's like, yeah, I love my power company. I want to give them all of my money. So people want to have solar panels. They want to have energy independence. And maybe our messaging is off. Maybe we can rebrand and say, you can have a green environment. You can have animals around your house. You can have energy independence. You can have water independence. And I think, unfortunately, you get into a lot of debates over whether this is man-made climate change or not man-made climate change. And that can unfortunately be a really big sticking point. So I don't know if it's an appropriate strategy to bypass the entire topic, but it might be a way of effectively achieving some of the goals that we have.
Yeah, I would just say too that one of my favorite parts about this field is the interdisciplinary nature of it. And we have seen huge success in individuals who have their PhD in climate communication, such as Professor Ed Maybach at George Mason University, partnering with meteorologists across this country to better improve messaging to targeted audiences. There is also really phenomenal work being done by our pediatric colleagues. One of my colleagues, Dr. Andrew Lewandowski in Wisconsin, he incorporates carbon footprint into every single one of his pediatric histories for well-child checks. And then he actually surveyed parents on both sides of the aisle in regards to like, how does this impact the care you perceive that you received? And on both sides, from a political spectrum, it was very well received. The kids loved it. And I think it's just a misperception, quite frankly, that this is polarized and people don't want it.
So just to, Caitlin mentioned Ed Maybach, and you had asked, is there any actual data, or do we know where people stand? So Ed Maybach is awesome and releases, it's every year, right? Every year he releases there's surveys that ask people, is climate change a real thing? How alarmed are you? Not alarmed, mildly, moderately, very alarmed. And it's been over a decade since he started it, I think. And you can see the transition. More and more people think that it's a thing that's caused by humans, and more people are at least somewhat alarmed by it, which I think is good because it's showing us, that there is actually numbers behind this. I think there's a feeling that people are caring more, but this is actually showing us that it does.
Thank you. So summarizing, it sounds like we generally feel that there's an improvement, right, in the general population's knowledge and understanding of the risks of climate change, but yet we have a ways to go. There is folks working on this at the level of expertise in communication, but there's also efforts from physicians and healthcare workers to actually talk about this with their patients, which I think is potentially a very impactful way to move that. So Dr. Rubley, why don't you tell us a little bit about some of the impacts on climate change on children that you might speak to, a patient, family about?
Yes. So children are one of our vulnerable groups that we talk about all the time when it comes to climate change. And there are several different reasons for this. One is just thinking about their vital signs and their underlying physiology, thinking about our respiratory rate, right? Some of it's almost double ours. And so just in regards to exposure of polluted air, for example, they're breathing that in faster. Their body surface area is also different. And then thinking about their activities and underlying behaviors is big. So the little ones crawl, right? And then they're exposed to various environmental factors. This is not a new concept. There's also mouthing behaviors. But then as they get older, thinking about things like exertional heat stroke in our athletes. And so with warming temperatures and depending on whenever their practices or games are, things like that, there's underlying susceptibilities. I also do think about medications as well, because some of the medications, especially in our teenagers, for behavioral health disorders and other things, actually increase the risk of heat-related illnesses. They're also dependent on others. So if we look at this from a global perspective, it combines with many other factors. Pediatric vehicular heat stroke is one example, right? Where if a kid is left in a car seat in a car, the hotter it is, again, it's mixed, it's an injury, but it's also, in the setting of warming planet, they're more likely to get sick sooner. There's also issues related to low and middle income settings that we need to talk about, and malnutrition is the big one. So thinking about global food security and the widespread ramifications of that. It's hard to care for a kid and promote health and well-being if you don't have nutritious food for them, at least routinely. And then thinking about some of these extreme weather events and the impact of displacement. Kids are in school, they're reliant on others. After Hurricane Katrina right here, if a child was displaced, the average time that they moved was 3 times. And so thinking about disruptions in community, family support, education, learning, and that inner social structure is really important. One other thing I'd like to mention is our healthcare systems. It's not something we talk about a lot. Here in our hospitals, we're really fortunate to have climate-controlled temperatures, right? But many healthcare settings around the world don't have air conditioning. And so there was actually this really cool study done that looked at the 2010 heat wave in a part of India. And what they did is it was a non-air conditioned hospital, and the maternal ward, labor and delivery, was on the higher floor. And they measured neonatal deaths due to heat stroke, essentially. And so what happens is during a 3-month period, there was 24 deaths of these neonates born in this maternal ward. Once they moved the maternal ward down lower, right, heat rises, to the first floor, they looked at 2 other years. The number of heat stroke deaths in these neonates decreased to 8 and 4 during 2 separate other periods. So just that simple step of moving and thinking about where we're placing at-risk populations is really important, and something here we don't necessarily think of.
That's a remarkable stat. I spend a fair amount of time working on maternal child health globally, and there's no interventions that I've worked on that would make that level of difference. So that's incredible. I want to come back to something you said and kind of think about the audience for a second, which is most of us take care of children, right? How many of us have taken care of children that are on behavioral or mental health drugs in the past year? Probably everyone in this room. And I will be the person to admit this. I have not once, and I live in California, it's relatively warm. I have not once talked to the parents or that child, which, I think teenagers, you can talk directly to them about that increased risk that you mentioned on those medications when they're out practicing, because they do practice, in my own children as well. And I'll be honest, I have my own children I have a child on medication like that, and I've never even thought about the increased risk that child is under. And so that just shows there's so much for us to be considering, and I think that would be a really impactful conversation with people if you can link it that directly, right? That heat illness, your child, increased risk, and things like that. So thank you for that piece of advice. And I think that shows a lot of ways that we can talk to parents. And Dr. Martin, maybe you can talk a little bit more about how you talk to parents and guardians, educate them. What are some of the key things, other things that you point to? How do you approach them?
Yeah, I think that a lot of times parents might not even be aware of the potential risks to their children's health that exist in the environment. I think a classic example when I was growing up was always we were always told to check and see if you had lead paint in your home. And that became a pervasive sort of messaging system, so that almost all parents knew about that. But most parents don't know about things potentially gas stoves. If you don't use the vent on your gas stove, it can increase your child's chance of developing asthma as they get older. So that's one example. But also, there are examples of exposure to green space and risks associated with living in a high traffic environment that can also increase your children's risk of developing respiratory illness. And you can educate parents in terms of what interventions they can make in their home. And one intervention might be purchasing an air filter, but you need guidance to figure out what type of air filtration device to buy. And you also need money to purchase that device. So what we can do as physicians, and I will say, physicians are one of the most trusted professions. If you look at the list of most trusted professions in the United States, lawyers are on the bottom, and then nurses are on the top, and then just below that are physicians. So it's important for us to remember, even in the wake of COVID, where people think that we're just trying to make money, people really do believe physicians. People trust us, and they listen to what we have to say. So I think that we have the power to advocate in our local communities, to advocate for policies that will particularly protect our lower income populations. So we can advocate for a credit to purchase these air filtration devices in urban areas. We can advocate for state policies to increase green space and allow for more planting of trees. And we can encourage our patients to advocate for those same sorts of initiatives. We have a powerful voice, and we're powerful, especially when we're unified together. So I think that we can educate our patients, but we can also help our patients through advocacy.
I noticed that among all of your bios that all three of you have participated in integrating climate and health into medical school curriculum. So as I listen to you speak and I reflect on my practice, I can admit honestly that I don't think I'm educated enough on this to be able to have those intelligent conversations, maybe at least as well as I'd like. So if maybe you could talk a little bit about, how that effort is going to integrate it into the medical school curriculum, where you think what you're focusing on, and this is across all of you, what are the areas that we need to kind of improve in that, how many places have that right now. And then I like that you mentioned nursing, because in general, I feel like nurses are highly underutilized, right? They spend more time at the bedside than us, and they're more trusted, as you mentioned, and they are at the patient's bedside, doing things and talking with them, and maybe that's an underutilized resource. So if there's any nursing programs that are integrating this would be another question. So lots of questions. Please, all three of you, take a crack at some parts of them.
Thank you for that question. It really depends on readiness for change at the place where you're at. And so we can be leaders in supporting our students first and foremost, because they're the ones coming to us saying, we want this now, how do we make it happen? And so we can help them draft a letter to the dean asking to incorporate it into new curriculum changes. We can start electives on climate and health that allow them to apply their area of interest and expertise over 4 weeks and craft that in a way that we in emergency medicine are already very adept at. We can also use our strengths in research in order to try and get funding or do projects. For example, most of my work is actually with the between first and second year medical students, where they get research time and a little bit of dollars that are supported by my department to do a project. And so just to give you guys an example, one of my students measured racial health disparities in regards to pulmonary function tests near coal-fired power plants in our state. Again, trying to think about policy implications, which I very much encouraged to shutting down those coal-fired power plants and what that means for health. Another student measured security transport emissions of our vehicles that drive around the parking lot for security purposes. How many, 200,000 pounds of coal burned just driving around patrolling our hospital to keep people safe. Right, again, linking to vulnerable groups and right where our patients and our employees go. And then there were many other observations that we weren't expecting. For example, the drivers kept the window rolled down, and so that's an occupational exposure for tailpipe emissions. And so what does that look like partnering with our Director of Sustainability or Waste for the system, partnering with Practice Green Health and some of these other organizations? We don't always have to know the answer, but I think serving as a model and working kind of across disciplines and directing these students has a real impact on how they think about problem solving, even as they move forward, and it really gives them skills and empowers them, even if there isn't a longitudinal integrated curriculum yet, which honestly is coming, so maybe.
Yeah, it definitely is. So I think there's probably dozens of institutions now that have at least some sort of climate and health education, which is really exciting. Lori actually gave a great talk about this the other day, but there's a few different ways to do this, and it's actually really low-hanging fruit, so if anyone's interested. Obviously, medical school curriculum is already very set. There are milestones. You have to do this, this, this. But climate change education is really easy to just kind of plug it into these things already, because you're going to be teaching about COPD exacerbations already. So you add one sentence in about in the setting of wildfires over the past 2 weeks, and then you make that connection. So it's literally as simple as that. Or you're teaching about ACS, and in the setting of an unprecedented heat wave, and we're on day 9 of temperatures above 35 degrees Celsius. So it really can be that easy, and just making that connection is really, really effective. And then there's also a few institutions doing dedicated climate and health curriculum. So instead of just sort of plugging these things into what's already standing, they start in their orientation, like medical school orientation, they have a half day devoted to like foundations of climate and health. And then throughout the next 2 years, they'll have their sessions here and there, and to to go more into detail about climate and health. But people don't have to be experts. Like, every medical student does not have to be an expert on climate and health, but as long as they're making these connections that poor air quality, higher air temperatures, disasters and extreme weather events, everything related to climate change directly impacts their patient's health, that's the most important thing you can teach. And then you had also mentioned nursing. I don't know a ton about how involved nursing is. I do know that there's quite a few different ways for them to get involved. But there was a publication last year in July in the Journal of Emergency Nursing, and this group had created an acronym specifically to help nurses talk to their patients about climate change in their health at the bedside. So that's called A-Climate. That was their acronym for that. And I don't remember exactly what it all stands for off the top of my head, but there's a ton of interest in the nursing world. And so the fact that there's already sort of a framework that's out there might be a good place to start if people are interested in sort of collaborating with their nurses in their institutions.
That's great. You know, as I think about what you're saying, you know, a lot of that is student focused, right, at the medical student level. Is there anybody in the audience that's at a program where climate and human and planetary health is like integrated into the curriculum of their trainees and at the resident level, where it's like designated component? Because they have all these hours that they have to check off. Does anybody have that as like there's designated hours and not just like it's the ad hoc version? I don't think we have that at Stanford. Anybody? So it makes me wonder, you know, our specialty leads in a lot of places, right? We believe that we're leaders in wilderness and environmental medicine. We believe we're leaders in global health. We believe that we're leaders, and we sit at the intersection of the community and the health system. So we should be leaders in this space, and I think due to people like yourselves, we are in some respects. But our specialty is not requiring, as far as I'm aware, please correct me if I'm wrong, because I do not know the answer to this, but as far as I'm aware, our specialty does not require that we learn about this. So as though we're telling medical students, like across others that are going to go into other specialties, hey, you should learn about this, you should learn about this, we as a specialty aren't. You know, do you think there's a place to advocate at ABEM and other, you know, societies that this needs to be mandatory curriculum for our trainees and then for our continuing medical education, which I am fairly involved with?
So from a resident perspective, I was a part of a survey for cord leadership, program directors and APDs. And essentially, there was a large proportion of them that weren't super excited about incorporating climate change into residency education. But they were excited about incorporating sustainability, environmental sustainability in healthcare. And so I think as we move forward and talk about incorporating this at all levels of training, quite frankly, as a way to enhance educational efforts, improve the care we provide, it's one of the things that I think we're going to see a lot of changes in. From a resident quality improvement perspective, there's a lot of low-hanging fruit in this field. And if you can connect, you know, reducing waste, plastic waste, improving time to administration of different pharmaceutical agents and medications, improving ED throughput, increasing the number of discharges, the sky's the limit, quite frankly. I think one of the challenges that we have is calculating the cost. So what is the return on investment of any of these initiatives? And this is a national problem. The National Academy of Medicine is working on a big collaborative action plan and initiative on decarbonizing the U.S. health system. So what that actually looks like is partnering with health services and infrastructure and all of these other entities to say what can be done. I like looking back to the Institute for Healthcare Improvement and kind of what was done with the medication errors and everything that has been done with Dr. Don Berwick, for example, over the last couple of decades. In a similar manner, I think the environmental footprint of the care we provide will be incorporated. When that happens and to what extent has yet to be determined. But there are a lot of really brilliant people working on it.
Yeah, I think, Matt, I would say it's coming. based on the motivation of the medical students that I think we've all worked with to really tackle the issue of climate change and planetary health, I think it's coming. And it's going to inevitably be something that we add into our curriculum at some point in the future. So I think that it's prudent of us to start thinking about how we can develop the concepts that we want our residents to be familiar with and what we would expect any general emergency medicine graduate to know and to be able to advocate for. So I think it will happen. Are we there yet? No, probably not. But just to piggyback off what Caitlin was saying, I think that in terms of our healthcare systems, we can each go back to our individual healthcare institutions and advocate for integration of climate change and planetary health into our respective medical school and residency curricula. We can advocate for funds to be directed to student projects and research. We can advocate at SAEM for grant funding to support climate change projects and research, like QI initiatives to try to reduce the footprint of our emergency departments. The emergency department is the front face of the hospital to the majority of patients. It's the only place that, like, most people aren't walking through the front door of the hospital to get admitted. They're coming through our emergency departments. So if we show in our emergency departments and we work on initiatives to green that space, then people are going to be familiar with this concept of more sustainable, more environmentally friendly healthcare. So I think that our emergency department should be the space where we should be working on this particular issue. I would also say, like, depending on the institution that you work at, it can be really easy to approach your administration and say, I would like to adopt this policy, or I'd like to look at this issue that I think can save you money and reduce waste. I think particularly in the community hospital setting, where you have a lot of access to your administration and you can approach them quite easily, you have a lot more power than you might realize to really make a huge difference in the way that your emergency department functions. And I would encourage you to, even if you're at a bigger institution, work with your leadership on projects to try to investigate how your emergency department creates waste, or how you, or to pursue projects that you think might make your emergency department more environmentally friendly or benefit patients in terms of their education. There's a great article that I don't know if people are familiar. The NHS in the UK, the National Health Service, has a commitment to become carbon neutral. So there's a great article in the British Medical Journal that talks about how to reduce the carbon footprint of your emergency department. And it's really small things, like turning off computers that nobody's using during the night shift. It's having computers go into a sleep mode. It's having different lighting sources in your emergency department. There are really easy ways for us to reduce costs for our administrators and reduce the carbon footprint for our world. So I would encourage you to pursue those sorts of projects.
Dr. Lindstadt, I know you work in this space as well. Do you have any kind of, like, here are kind of my go-to things that I would start with for the average emergency department, which can't even turn off its computer in its office for 2 years during the pandemic?
I don't know if I necessarily have a go-to thing, because I think every place is different.
So how do you decide then what works for your place? Like, what's our take home as far as that goes?
I think if you can talk to the people you work with and you can sort of gain their interest in, I think that if you talk to your colleagues at work and just say, man, isn't it crazy how much stuff we waste every day? Every single person is going to be, I know, oh my gosh, like, I can't tell you the number of times I've had that conversation. So everyone is aware, I think, at least that we waste way, way, way too much. And I think everyone wants to minimize that. And so just by talking to them, you can sort of say, I do this to help. So I don't crack open an IV kit every time I need a tourniquet. I go find a tourniquet. Or really little things, or like changing your printers to be like print both sides instead of one side. That's something you can talk with your unit clerk about. So depending on who you're talking to, you can try to kind of put an idea in their head about what small difference they can make. And then with, hopefully the intention of most people in your department will be interested in this, and maybe you can go forward and implement larger changes. I think one really helpful thing is if you can do something like a waste audit in your emergency department, and Jonathan Slutzman has a really good paper out of that, where they, just for 24 hours, they collected all the waste that was produced in their emergency department, and so they can quantify how much is actually going to waste. And it was 3 kilograms of waste per emergency department encounter, which is out of control. And then they can then put a price tag on that and show, this is how much we're wasting, like dollars we are literally throwing away. Let's make a change. So I think the more data you have, the better it is. But you will be surprised at how many people are already thinking, we waste so much, we need to stop doing that.
So Jonathan Slutzman article in, do you know, just in West Gem? Okay. So we're going to all Google that, find it, and then we're going to use that to potentially conduct waste audits, right, in our emergency department. I think the timing of this conversation is good in that one of the first things I heard with the PPE usage, right, for all of us during COVID was people started to recognize the extreme quantities of waste because we tripled it almost, right? All of a sudden you're wearing gowns and everything and double masking, and then most of us had problems actually with staffing and getting enough of ancillary staff to support cleaning things. So we all had the, hey, I don't know if I should push my hand into this to push the garbage deeper, right? Or if there's something sharp in there moment, right? Where you can just throw it on top and be like, I'm just not trusting. So, this is probably a good time for that conversation, but I think we need some expertise. So it sounds like there's some articles out there that we can do, doing a waste audit and then starting small. I do like to operationalize things, having an ops background. And I think if you can identify the things, most clinical operations people are very amenable, but they won't be, they're so busy in clinical operations, they tend to not be able to take the time without to be an expert in that. And so I think you'd have to serve as the expert and then just ask them to operationalize it, right? I know that's how I would approach my ClinOps team.
I would just say that procurement's an excellent partner as well. And so the people purchasing any of these products for our emergency departments often, aren't the end users. And so I've learned a lot in talking with them. And one example are like plastic disposable vaginal speculums, right? So many of them are completely disposable, and so they don't have a reusable battery. And so actually if you pull out the tag, there's 2 lithium button batteries in every single one. That just gets thrown away. I was like, this is not okay. And so it's been really fun, even making that small change of let's use reusable batteries, and knowing our literature that our colleagues right here as part of SAEM have curated of like when are the clear indications for a pelvic exam versus just self-swabbing, for example. And so that was just one example that I was able to work with more in a community site to just make a small change. And it was actually one of the techs who brought it up to me. And so it was this really beautiful partnership, and they were really quite empowered by it.
I like that, working with procurement. And does anybody else in the audience have, an experience where they worked to do something like this, reduce the carbon footprint of their emergency department or operations, wants to share it?
We're doing a very small, nothing like the dumpster diving project, which was phenomenal. But this is an itty-bitty project, super easy, that medical students initiated, looking at red bag waste in the emergency department. And we're going to do an intervention and then study it again and hopefully change change the way things are. It's already approved, so.
So people can reach out to you in your name again, sorry? Lori Thibodeau. Reach out to Lori and she'll give you the smaller version of the waste audit. I spend a lot of time thinking about change and how we motivate and stimulate change. And a lot of times you have to tie that to something else that's important to the decision makers, right? That's like what I spend 80% of my time thinking about. So in this case, there's two things that have come up to me, right, as I think about this. One is oftentimes the things that around this, just like all the waste, there's some cost benefit that you can show as well, right? It's not, we always think it's cheaper, but it's not actually cheaper once you take into account all of the waste disposal and things like that, which is very expensive for healthcare systems. So, getting your leadership at the hospital on board oftentimes is about money, especially right now, because most of our health systems are running on very small margins. So talking to them about like, hey, or procurement, about what's really expensive for you, right? Oh, and then like, hey, what other options are there out there? Get some of those folks thinking about it from a cost perspective, I think might be one approach that could be particularly useful. And then the other change management piece that came up while you were talking was, well, if I went to my residency program right now and asked them for some space for human and planetary health, I would probably get 15 minutes on, at 7 in the morning, which is better than nothing. But I would be highly not satisfied with that. At the same time, you saw the energy at the opening ceremony here, right? Around social justice, around racism, around health equity. This is a health equity issue, right? And I don't know how many of you out there work in a place where health equity is now part of the curriculum for your trainees, but we've instituted it as a designated part. We do health equity rounds. It's integrated in our didactic curriculum. And maybe the thing that I need to be asking at Stanford is, can we have part of that health equity? And during health equity, can we talk about health equity and human and planetary health in that intersection? Because that's a really important space as well. And so a lot of times to make change, you have to find what is a very moving topic at the moment and attach yourself to that. So. Has that been talked about a lot or done places that you're aware of?
It falls under social emergency medicine initiatives pretty nicely. And so I've worked in a couple different places, and at my current institution, I'm the only one who does this work, which is probably pretty common right now until we garner support. And so it's part of our social emergency medicine residency curriculum, and I'm able to give a couple of lectures a year related to that. And then do some of these other projects. And ultimately, it supports the mission and vision of any of these health systems. And so again, anytime you can link it back and demonstrate your value is really important. The reason why I do this work is for advancement of health equity and the climate justice component. You can talk about it from a high versus low and middle income country setting, with disproportionate burden in low and middle income countries related to high emitting countries such as the United States. But you can also see those same issues across zip codes right in our own cities and communities. And so I've been able to work with all these different partners at the city level with our academic institution to talk about redlining and how historical housing policies to this day impact energy burden, and that Black and Latinx members of my community have pay more for any of their energy than the white members of our communities related to these redlined areas. These are the same locations that have higher heat, and so again, the risk of serious life-threatening consequences related to heat exposure is greater. So anytime you can kind of connect that and make it local, partnering with some environmental groups, with some of the climate action and health groups, really valuable. I'll put a plug in for the Medical Society Consortium on Climate and Health. It's a national organization. SAEM and ASAP are both members. And so they have a whole bunch of different resources that can connect you to local issues so that you don't have to duplicate efforts and you can learn about it.
I'd say I work in global health as well, and this is planetary health is global health. They're all in the same field. I mean, I know you work in global health as well, Matt. And one of the steps that we're taking with our fellowship program at Brown is trying to figure out where climate change and health belong. And it certainly belongs in global health. So Dr. Kate Moretti, who's one of my colleagues at Brown, she looked at our division, which is one of the biggest in the country. We have 20 people in our division of global emergency medicine at Brown. And she calculated the carbon footprint pre-COVID of all of our flights over the course of 2 years. So we could get an idea of how much our global health department is polluting. Like how are we contributing in our efforts to try to improve health? How much are we causing harm in our efforts to try to improve health? And that's led us to the point now where we're discussing with our entire department, how can we reduce our carbon footprint, and can we use department funds to cover offsets, for example, for some of the travel that we're doing. And then, like I mentioned, trying to integrate some of the principles of climate change and health into our fellowship curriculum so that our fellows are aware of the potential impacts of their activities and can utilize more hybrid formats, so teleteaching or other avenues to try to be more intentional in their carbon emissions and carbon footprint when they're doing global health work. The other thing I'll say, and this might be a little bit controversial, is that when we talk about climate change and equity, we need to talk about the process that we use for selecting medical students and residents and consider maybe changing that process to either a hybrid process or a remote process. One thing that COVID did is it forced us in the direction of having to do remote interviews. And what that did is unintentionally led to more equality among access for medical students when they were applying to programs. The burden of having to shoulder the costs of flying across the country to interview at different residency programs is real. And it restricts a lot of medical students and residents from applying to the programs that they really want to apply to. So I think by rethinking the way that we go through the process of having students and residents apply for these things, we can create a more just environment, but also a more environmentally conscious process.
Thank you. I think we've covered a ton of ground, right? And I think we should think about it as a ton of opportunity. So we're not going to all be able to tackle each of these spaces, but if we can pick one or two spaces. We are just about out of time, so we probably have 2 minutes left. Are there any questions from the audience? Anyone have a burning question that they'd like to ask while they have these three here? Please go ahead, sir.
Yeah, so my 12-year-old granddaughter, recently, she and I had this conversation about what she's learning in science, and they're learning about global warming. And so I started sending stuff to her, emailing things to her, and her mother, my daughter, said, "Please don't do this, you're scaring her." What do you guys think? What's your reaction?
There was just an article that came out. The author was Ma M.A. But essentially, it looked at the mental health effects of the climate crisis for our young people. And I think we have a real opportunity to take that and be sources of support and help them develop their own skills to guide action. Because if you can act and see solutions through some of the weeds, you're going to be inspired and motivated. And especially I think about our young girls and developing leaders and what that could look like. It is a profound opportunity, not only in this country, but other countries as well, to help them see opportunity, give them the skills to be able to guide action and work, again, across different organizations and disciplines. And I've seen that be really powerful right in my own community.
I definitely get that. It's scary. Of course it's scary. This whole, it's called eco-anxiety. Eco-anxiety is what people feel. The anxiety of having to deal with the catastrophic implications of climate change. I've certainly had a ton of eco-anxiety, and sometimes this work seems so daunting, like, how am I going to keep doing this? It's so scary sometimes. But I think to Caitlin's point, there's such an enormous opportunity to make a huge change in I can't imagine a more significant problem, and that we can protect the health of the human population in this century. That's an incredible opportunity. And I think one piece of advice I have in terms of eco-anxiety is that you as an individual are not going to solve this problem. So no matter how many vegetarian meals I eat, no matter how much I ride my bike to work, I am not going to fix climate change on my own. And so keeping that in mind, while still knowing that it's important to be involved and push it forward as a group and as a team, that we need to be focusing on that. But if we're trying to silo our entire climate change problem to one individual or one person, obviously we're not going to be successful. So just keeping in mind that we have the solutions, and we just need essentially cooperation and the motivation to fix this problem. I think that's how I have dealt with the sentiment of it's scaring her.
Yeah, I mean, I'll just say that I don't think we can protect our children from the impacts of climate change. And I think it's unfair to not give our children the opportunity to solve a problem that they're going to face. It amazes me, this generation's ingenuity, their community engagement, and their belief in social justice and equity is at a level that I would have never fathomed 10 to 20 years ago. And so I worry that if we don't put these challenges in front of our children directly and openly, then we're telling them that we don't believe in them as people that can find the solutions to these challenges. Because we can't protect them from the changes, but we can at least give them the opportunity for them to solve those challenges. I think we are out of time, and I really want to thank everybody for participating. Please put your hands together for our panel.